Evaluation of a continuous murmur requires a systematic approach to differentiate between benign physiological flows and complex pathological shunts. A continuous murmur is defined by its timing. It begins in systole and continues through the second heart sound into part or all of diastole without interruption. Continuous murmurs are generated when there is a persistent pressure gradient between two cardiovascular structures or vessels throughout the cardiac cycle. This results in uninterrupted blood flow from a high pressure or high resistance system to a low pressure or low resistance system. It is vital to distinguish a true continuous murmur from a to and fro murmur. In a to and fro murmur, example combined aortic stenosis and regurgitation, blood flows in opposite directions during systole and diastole. In a true continuous murmur, blood maintains the same direction of flow across both phases. The causes of continuous murmurs are broadly categorized based on the site of the shunt or the nature of the vessel involved. High pressure to low pressure shunts. Patent ductus arteriosus. The most classic cause. It produces a missionary-like murmur loudest at the left infraclavicular area or second left intercostal space. The systolic component peaks at S2 and continues into diastole. The murmur is also known as Gibson's murmur and train in tunnel murmur. Ruptured sinus of valsalva aneurysm often presents with sudden onset chest pain or dyspnea. The murmur is typically loudest at the lower left sternal border and may radiate to the xiphoid process. Diastolic accentuation is a classic feature of RSOV into RV as the tract gets compressed in systole, reducing the intensity of systolic component. Coronary artery fistula, a rare anomaly where a coronary artery communicates with the heart chamber or the pulmonary artery indirectly. The location of the murmur varies depending on the drainage site. Example, right atrium versus pulmonary trunk. A fistula communicating to a cardiac chamber is called coronary cameral fistula. Physiological and extracardiac flows. Cervical venous hum, a common benign finding in children and some young adults. It is best heard in the right supraclavicular fossa. It is highly position dependent. It typically disappears when the patient lies supine or with digital compression of the internal jugular vein. Mammary souffle occurs during late pregnancy or the postpartum period due to increased blood flow to the breast. It is loudest over the breasts in systole and diastole and can be abolished by firm pressure with the stethoscope. Arterial and venous obstructions. Severe arterial stenosis. High-grade stenosis, typically more than 80% in vessels like the renal, carotid or femoral arteries, can generate a continuous bruit if the pressure gradient remains high throughout diastole. Creulia-Baumgarten syndrome, a continuous venous hum heard in the epigastric region due to dilated paraumbilical veins in the setting of portal hypertension. Physical examination findings and dynamic maneuvers are the first steps in narrowing the differential diagnosis. Maximal intensity in case of PDA is left upper sternal border or left infraclavicular region, while in ruptured sinus of valsalva, it is lower left sternal border or xiphoid region. In venous hum, it is right supraclavicular. Pulse quality is bounding wide pulse pressure in PDA, collapsing in ruptured sinus of valsalva, and normal in venous hum. Could be slightly high volume if there is severe anemia. Maneuver effect, little change with position of PDA, intensified by hand grip in ruptured sinus of valsalva. As the afterload increases, the leak increases. Venous gum disappears in supine position. ECG may show evidence of chamber enlargement like left ventricular hypertrophy or volume overload in PDA. Chest X-ray can identify pulmonary plethora or specific contours, example prominent pulmonary artery. Transthoracic echocardiography with Doppler, the gold standard for initial evaluation. It confirms the presence of shunt, determines its direction, and assesses hemodynamic impact. Advanced imaging like CT MRI and transesophageal echocardiography indicated for complex anatomies like coronary pulmonary fistulas or when TTE, transthoracic windows, are inadequate.